Welcome back to Good Doctor. Today we'll be dealing with pharmacology. Yes, LOL. Beta adrenergic blockers, where we'll be dealing with hell lot of LOLs. What are beta adrenergic blockers? They inhibit the adrenergic response mediated through beta receptors. All beta adrenergic blockers are competitive antagonists. First, let's see the classification. They're broadly classified into non-selective and cardioselective. The non-selective group of beta blockers are then further classified into those without intrinsic sympathomimetic activity, which are propranolol, sotalol, timolol. Those with intrinsic sympathomimetic activity, such as pentalol, and those with additional alpha blocking property, such as levetolol. Then the cardioselective beta 1 blocking receptors, blocking drugs. Examples are metoprolol, atenolol, acebutolol, etc. The more common classification is based on their generation, first, second and third generation beta blockers. The first generation, which are non-selective drugs, which include propranolol, timolol, sotalolol, pentalol, and levobutanol. The second generation, which are beta 1 selective drugs, which include acebutolol, metoprolol, atenolol, bisoprolol, esmolol. And the third generation drug, which also has an additional alpha blocking and vasodilator property, which are labetalol, carvedilol, celiprolol, nebivolol, and betoxolol. From these, the nebivolol and betoxolol have beta 1 selective blocking activity. Of these drugs, pindolol, acebutolol, levetolol, celiprolol, and carvedilol has partial agonistic activity, which is they stimulate the beta receptors in absence of catecholamine. And some other drugs, which are propranolol, acebutolol, carvedilol, levetolol, metoprolol, and pindolol, have membrane stabilizing activity, so that they can act as local anesthetic. The mechanism of action. Propranolol is the prototype drug of beta adrenergic blockers. Beta adrenergic blockers competitively block the beta receptor mediated catecholamines and other adrenergic agonists. What are the pharmacological properties of beta blockers? They have various effects on cardiovascular system, respiratory system, skeletal muscles, metabolic effect, and on eye. Let's see in detail. On cardiovascular system, on the heart, it has negative chronotropic effect, which is it decreases the heart rate. It has negative inotropic effect, that is it decreases the force of contraction. It decreases the cardiac output. It depresses the nodal activity. It increases the refractory period of AV node. It decreases the conduction in atria and AV node, that is negative dromotropic effect. On the blood vessels, it initially increases the peripheral vessel resistance due to unopposed alpha 1 action, but later it decreases the peripheral vessel resistance and hypertension due to decreased cardiac output. It also decreases renin production from the JJ apparatus due to blockade of beta 1 receptors and decreased central sympathetic outflow. On the respiratory system, the beta blockers should not be given to patients with asthma and COPD. Why? The blockage of beta 2 receptors causes bronchospasm in patients with COPD and asthma. Selective beta 1 blockers may not cause bronchospasm, which are atenolol and metoprolol. Then skeletal muscle. Chronic use causes weakness and tiredness of skeletal muscles due to beta 2 blockade. It also reduces stress-induced tremors. 4. On metabolic effects. It inhibits glycogenolysis, that is conversion of glycogen to glucose in the liver, and also delays the recovery from hypoglycemia. It also masks the warnings and symptoms of hypoglycemia. Therefore, it is to be cautiously used in diabetics with hypoglycemic agents. The chronic use decreases the HDL to LDL ratio, thus increases the risk of coronary artery disease. On eye, beta blockers on topical administration decreases the intraocular pressure by decreasing the production of aqueous humor. Then pharmacokinetics. Beta blockers are highly lipid soluble and thus it is easily absorbed from the GIT. It has high first pass metabolism and hence low bioavailability. It is highly bound to plasma proteins and have large volume of distribution. Since it is highly lipid soluble, it can freely cross the blood-brain barrier and the metabolites are excreted in urine. Then, the adverse effects of beta blockers. It can be easily understood from the pharmacological properties that it has adverse effects over the CVS, RS, CNS, the metabolic effects, and over the muscles. In detail, 1. On CVS. It causes bradycardia, heart block, congestive cardiac failure in patients with low cardiac reserve. Beta 2 blockade causes unopposed alpha 1 action, which reduces the blood supply and worsens the peripheral vascular disease. Beta blockers is contraindicated in Prinzmetal's angina, which is the variant angina, due to unopposed alpha 1 action. On respiratory system. Beta 2 blockade causes bronchospasm in COPD and asthma patients. Therefore, it is contraindicated in COPD and asthma. On the CNS, it causes sleep disturbances, hallucination, fatigue, and mental depression. 4. On the metabolic effects, it delays the recovery from hypoglycemia. It may mask the warnings and signs of hypoglycemia. 5. Muscular weakness and tiredness. Due to the reduced blood flow to the skeletal muscle, it causes muscular weakness and tiredness. 6. Withdrawal symptoms. Sudden withdrawal after chronic use of beta blockers may elicit angina, frank myocardial infarction, or even sudden death. This is due to upregulation of beta receptors in response to the long blockade. Then let's see the drug interactions when the beta blockers interact with other drugs. First, verapamil. It causes an additive cardiac depressant effect, which causes congestive cardiac failure, bradyarrhythmias, heart block, and even cardiac arrest. 2. With lignocaine, it induces clearance of lignocaine by decreasing the hepatic blood flow. 3. With cholestyramine and cholestyramine. These are bile acid binding resins. They bind with beta blockers in the gut and prevents the absorption of beta blockers. 4. With insulin and sulfonylureas. It has the non-selective beta blockers inhibit glycogenolysis and delay the recovery from hypoglycemia. A schematic representation of this is given below. Insulin or sulfonylurea, which are anti-diabetic agents, decreases the blood sugar level, causing hypoglycemia. This leads to a sympathetic stimulation of the liver, which converts the glycogen to glucose. The heart, which responds with tachycardia and palpitation. Skeletal muscle, which shows tremors. Propanolols and other beta blockers, when given, it causes delayed recovery from hypoglycemia as it inhibits the conversion of glycogen to glucose. It masks the warnings and symptoms of hypoglycemia, such as tachycardia, palpitation, and tremors. It also causes vasoconstriction and rise in BP due to unopposed alpha 1 action. 5. With non-steroidal anti-inflammatory drugs. With NSAIDs, by inhibiting the prostaglandin synthesis, it promotes sodium and water retention. On chronic use, they decrease anti-hypertensive effect of beta blockers. 6. With chlorpromazine. Propranolol interferes with the first pass metabolism of chlorpromazine and increases its bioavailability. Then the therapeutic uses of beta blockers. It is used in a wide variety of cases. 1. Hypertension. It is useful in all grades of hypertension. It is preferred in patients with angina, myocardial infarction, and cardiac arrhythmias. The advantages are sodium and water retention is rare, it is cheaper, longer duration of action, and it is well tolerated. 2. Angina prophylaxis and myocardial infarction. Beta blockers reduce the myocardial oxygen demand by decreasing the heart rate, myocardial contractility, and arterial pressure. It increases exercise tolerance, decreases frequency of episodes. It is used in acute phase. Its use in acute phase decreases the size of infarct. Its long-term use may reduce mortality and reinfarct. 3. In congestive cardiac failure. Chronic use of beta blockers such as carvedilol, metoprolol, and bisoprolol reduces the mortality rate in CCF. 4. Cardiac arrhythmias. It is mainly used in atrial arrhythmias such as atrial fibrillation, atrial flutter, and PSVT, but rarely for ventricular arrhythmias. 5. In pheochromocytoma. To control the cardiac manifestation of pheochromocytoma, but it should not be given alone. The beta blockers should not be given alone. 6. In glaucoma. Beta blockers decreases the intraocular pressure by decreasing the production of aqueous humor. Timolol, cartellolol, levobunolol, betaxolol are used typically to treat glaucoma. Timolol is most frequently used drug. Betaxolol, it is a selective beta 1 blocker and hence has systemic adverse effects are rare. 7. In prophylaxis of migraine. Propranolol and metoprolol decreases the frequency of migraine headache. The exact mechanism is not known. 8. In essential tremors. Oral propranolol is given in essential tremors. Treatment of essential tremors. 9. Hypothyroidism. The symptoms of hypothyroidism such as tachycardia, palpitation, tremor, etc. are reduced due to the blockade of beta receptors. Propranolol inhibits the conversion of T4 to T3. It is used in thyroid storm. 10. In acute anxiety state. Beta blockers are useful in controlling palpitation, tachycardia, tremors, sweating, etc. 11. In alcohol withdrawal. Propranolol may be beneficial in alcohol withdrawal. 12. Hypertrophic obstructive cardiomyopathy. It decreases the outflow resistance. Beta blockers decreases the outflow resistance. 13. In dissecting aortic aneurysm. Beta blockers decreases the cardiac contractility and rate of development of pressure during systole. Now let's see some of the beta blockers in detail. First, the selective beta 1 adrenergic blockers. Esmolol. Esmolol is given as IV administration. It has a half-life of 10 minutes. It does not have membrane stabilizing effect, that is, it has no intrinsic sympathomimetic activity. It has short duration of action. It is used for rapid control of supraventricular arrhythmias. It is useful in hypertensive emergencies. 2 is atenolol. It is also a selective beta 1 blocker. It does not have membrane stabilizing effect. It is polylipid soluble and hence central side effects are rare. It has longer duration of action and can be given once daily. Here are some of the differences between propranolol, which is a non-selective beta blocker, and atenolol, which is a beta 1 blocker. Propranolol in large doses has membrane stabilizing effect, that is, it acts as a local anesthetic. Atenolol does not have membrane stabilizing effect. Propranolol is a highly lipid soluble and thus can cross the blood-brain barrier, and therefore it can produce central side effects. Atenolol is polylipid soluble, hence central side effects are rare. Propranolol has a shorter duration of action, but the propranolol SR formulation has a duration of 24 hours. Atenolol, on the other side, has a longer duration of action and can be given once daily. Propranolol is a less potent drug, while on the other side, atenolol is more potent. Then, the beta blockers with additional vasodilatory action. 1. Labetalol. It is a competitive blocker at beta 1, beta 2, and alpha 1 receptors. It has partial agonistic activity at beta 2 receptor. It can be administered orally and through IV. The oral labetalol has extensive first pass metabolism and hence low bioavailability. The IV labetalol is used in hypertensive emergencies. It is used in essential hypertension. It is safe to use during pregnancy. The side effects of labetalol are postural hypertension and hepatotoxicity. 2. Carvedilol. It blocks the beta 1, beta 2, and alpha 1 receptors. It has antioxidant, anti-proliferative, membrane stabilizing, and vasodilatory effect. It does not have intrinsic sympathomimetic activity. It has cardioprotective effect, and long-term use reduces mortality in congestive cardiac failure. 3. Celiprolol. It is a third generation selective beta 1 blocker. It has weak vasodilatory effect due to nitric oxide release. It has a weak bronchodilatory effect due to beta 2 agonism. It does not have membrane stabilizing effect. It is used in hypertension and angina. 4. Nebivolol. It is a third generation selective beta 1 blocker. It has nitric oxide mediated vasodilatory effect. It does not have membrane stabilizing effect. It does not has intrinsic sympathomimetic activity and no unfavorable effect on lipid profile. It is used in treatment of hypertension and congestive cardiac failure. That's all about beta adrenergic blockers. Thank you.